Welcome everyone to the KTOO 360 North Auditorium. We are here tonight to discuss mental health and substance abuse treatment in Alaska, a retrospective panel discussion. I will go through our panel members in just a moment and give you a little more information about what we're going to talk about tonight. My name is Diane Casto. I am currently the Executive Director of the Council on Domestic Violence and Sexual Assault here in Juneau, and I've worked for the Department of Health and Social Services for over 22 years in child protection, juvenile justice, fetal alcohol syndrome, behavioral health. So I have been around a while. I was telling someone recently, I signed a 3-year contract originally to come to Alaska. Now it's 30 plus years. So I think I can say that's probably true for most of us, or many of us. So the purpose of this evening's discussion is to capture some of the history of how Alaska's behavioral health treatment system has evolved into what it is today. We want to look backward in order to look forward. So the kind of the old saying, don't, learn from your mistakes and use your history to take you forward. So that's what we're going to talk about tonight. First, I want to thank 360 North and KTOO for hosting this event. And this event is being made possible by the Alaska Behavioral Health Association, working in partnership with the Alaska Mental Health Board and the Advisory Board on Alcoholism and Drug Abuse. Tonight's discussion is being recorded in front of a live audience. We have a full house here tonight, which is pretty exciting, and will be broadcast statewide at a later date. We have 90 minutes for this discussion, and when I first heard that, I said, seriously, 90 minutes to talk about mental health and substance abuse in Alaska over time? So with that said, it's quite the ominous task ahead of us, and we will do our best to stay on track. We recognize this event is only the beginning of a conversation, and that we hope that some of what we discuss tonight will be carried on in dialogues and discussion in the future. The topics require a much more complete discussion than what we'll have time for tonight. And unfortunately, because of the time and the format, we will not be allowed to open discussion for the audience members during this 90-minute discussion at this point. Now, if we get ahead of ourselves, we might be able to do that, but the plan is to not have question and answers from the audience. So what I'd like to do first is to just give a brief introduction of this esteemed panel. I was telling folks that for me, it's like old home week. I feel like I'm having a family reunion with people that I've worked with for a number of years and I have a lot of history with. So first, next to me is Jeff Jesse. He is the Dean of the UAA College of Health and the former CEO of the Alaska Mental Health Trust Authority. Next, we have Vernee Berner, President and CEO of the Alaska Native Health Board and a trustee of the Alaska Mental Health Trust. Then we have Pam Watts. Pam Watts is from Juneau. She is a former executive director of the Juneau Alliance for Mental Health and the Rainforest Recovery Center at Bartlett Regional Hospital. Next, we have Kevin Munson. Kevin is the CEO of the Matsu Health Services, Inc. And then Bill Hogan, carrying up the rear there. We're telling him to stay close here, Bill. Former commissioner of the Alaska Department of Health and Social Services and my former boss for many years. No problem. Yeah, talk about herding cats. I was one of those cats. So what we're going to do tonight is we have 10 prepared questions. Now, obviously, we can't all talk and answer each of the 10 questions because we would be here till late tonight. So what we're going to do is I'm going to start with the first question and let everyone have an opportunity to respond to it. And then some of the next questions I'll target one or two people, but everyone has an opportunity to join in and answer those questions, because we don't want this to be just a stifled conversation. We want it to be give and take, and we want you to add as you feel necessary. So if you have additional things to add, please just speak up. So the first question we have is, what have been some of the most important developments in the evolution of our mental health, drug, and alcohol treatment systems in Alaska? And I'm actually going to start with Jeff, because Jeff has some unique history on the service system in Alaska and has been fighting for this system for many years. So Jeff, we'll start with you and then we'll go down the line.
Well, statehood was really one of the first major milestones because during territorial days, anyone with any mental disability, whether it was a mental illness, substance abuse, dementia, or developmental disability, they were actually convicted of a territorial crime of being an insane person at large. And a federal marshal would fly you to Morningside Hospital in Oregon, and many Alaskans were sent there during territorial days. Well, during the discussion about statehood, this became a real problem, not only because Alaskans hated this so-called mental health system, but when we became a state, we would have to pay for Morningside. And we had no visible means of support. This was before oil. So Congress spent 3 years fashioning the Mental Health Enabling Act, which gave us some cash to build API, the original Alaska Psychiatric Institute, and to build a hospital in Valdez for people with developmental disabilities, gave us a little bit of cash to sort of wean us off of the federal dole, and created a 1 million acre land trust to provide long-term funding for mental health.
And this is the only state that's done that?
Yes, this was the only state that had that type of an enabling act.
I think that is so important that this history really does lay the foundation of how we started our system and where it has built from there. So, Renee, do you have any additional moments or important developments in the evolution?
I do. I would like to go ahead and start again. Alaska Natives have been here for many millennia, and they have withstood some of the harshest climates and the harshest geographies in the United States and truly in the world. And they have survived and have had a real sense of resiliency throughout famine, throughout just some of the harshest environments overall. And with that, they have built within a culture that really supports and sustains one another. And so there are some real traditional ways that mental health was addressed traditionally, and for us, it goes back to those many, many generations. But Alaska is also unique in so many other ways, and bringing into the future, into the current arena, and looking to the future. Alaska has dealt with some of the harshest and most sparsely populated lands across the nation, and we have been innovative in the ways that we've addressed that or working to address it. And I think one of those unique aspects of Alaska that is a model for the world and for the lower 48 as well, in creating the Community Health Aid Program, and with that, the dental health aid therapist program, and also the behavioral health aid program. And so I think those are some exciting developments that are unique to Alaska, but are a beacon and a model that we can emulate and spread, and we are looking to do so.
Mm-hmm. You know, and it's interesting, so I am now in more the public safety arena, but one of the things we talk about is that just what you have mentioned, the community, behavioral health aides, the community health aides, those kind of programs, along with the village public safety officers, those kind of programs are all about public safety as well as health. I mean, if we don't have healthy environments and healthy communities, we also don't have safe communities. So they really go hand in hand. Yeah, thank you. Pam.
Well, I was fortunate enough to move to Alaska with my family just before statehood, and I can remember some of those early days Jeff was talking about, and I went through Alaska Methodist University for my undergraduate work, and I remember one of my classes went on a tour at API, and those were the days when psychiatric hospitals all over the country were using a lot of Thorazine, for example, to medicate people, and API was not an exception. And I've often thought how far we've come from those early days in the advancement of treating mental illness and addictions. And I remember around that time in the early 70s, Salvation Army had a program downtown in Anchorage where it was a residential program where individuals could come and do chores and, you know, attend worship services and get a meal and have a place to stay. And, you know, when you look at what we have today compared to those early days, we've really come a long way. I do think that some of the other developments, I mean, what evolved from that was the establishment of, under the State Department of Health and Social Services, a chemical dependency division and a division of mental health and developmental disabilities. So those functioned for many years to administer grant funding and other resources to help grow the infrastructure statewide. And so I think one of the significant changes in more recent years has been the addition of Medicaid funds to help support some of that grant funding, although the grant funding then has subsequently dropped away. But there were kind of pros and cons with that. I think that you know, we're a little more restricted in our Medicaid funding about what we can bill for than perhaps we were with the grant funding. But it certainly has allowed us to serve a greater number of people, and I see that as a real positive too. Right. And then ultimately those two divisions of mental health and chemical dependency merged and became what's now the Division of Behavioral Health. And I think that has really supported the integration of care and a more holistic approach to treating people and addressing all of their needs, and I think that's a real plus too.
You know, you mentioned that our service system has really improved over the years, and I think back to something Jeff said about the how we looked upon mental health and substance abuse illness back in those days. And we certainly, I think Alaska has done a really good job, and we can talk about this more later, but in changing the attitudes that mental illness and substance use disorders are not crimes. They are not anomalies. They are not something that you put someone away, and I think we have done a really good job. And when we talk more about the Mental Health Trust, I think they have done a really good job of that as well, of changing some of those attitudes, so which helps us move everything forward. Kevin.
I came up in the late 80s, and the principal reason that I was brought up to Alaska was to help the local agency in Wasilla to build out a community support kind of program to serve the community needs of the severely mentally ill. And so the combination of additional oil revenue that had come in with state grants, the federal dollars that were coming through the community support service grants through NIMH, and then the state making the decision to both adopt the clinic option and in particular the rehab options for Medicaid, really permitted the communities to begin to build out the necessary services for psychiatry and case management and clinical care. We ran scattered site apartment programs and clubhouses, and we were involved in various supported employment activities. And that really ended up being extremely valuable because one of the early decisions, Jeff talked about the initial building of API. Well, in the late 80s, there was kind of a lot of discussion about how big should API be. And so there was the Alyeska Accords, if people have been around long enough to have been in those meetings, where the size of API was kind of determined through this interesting process. But that was predicated on the community continuing to build out. And for a number of years, we were able to do that. And then fiscal realities kinds of hit and other things changed. But I think some of the other big kind of historical milestones was in the 90s then the real focus on community mental health centers becoming co-occurring welcoming and co-occurring competent, which ultimately led to the whole notion of integration, and ultimately, as has been mentioned, was that the division put itself back together, and we ceased having this kind of artificial dichotomy based on what section of the DSM did you happen to fall into. And I think that particular policy decision and then the subsequent decisions to really focus on trying to integrate care, and then a focus on trying to integrate care with primary care, became some of the big kind of policy wins that the state is still trying, I think, to struggle through and to build out.
I would agree with that. I think we've certainly started that, but we're not quite there yet, and there's a lot more opportunity for us to combine primary care and behavioral health care. And Bill, you were actually at the Division of Behavioral Health when it first came together.
Yes, I had the good fortune of being the first director of the Division of Behavioral Health when we merged the previous division of mental health with the previous division of alcohol and drug abuse. And what we tried to do was to create a division that would support an integrated system. Because what we discovered was that actually 65% of the people that we were serving in both the mental health and substance abuse system actually had both problems, a co-occurring disorder. And so we tried to create a system that was comprehensive. I still to this day talk about the continuum of care, starting from prevention through early intervention, through treatment and recovery. So it wasn't just about the treatment aspect, it wasn't just about how do we support people for the long haul, but how do we actually prevent these kinds of problems from occurring, and how do we intervene early enough to keep problems from becoming more severe. So I think we had the good fortune of being able to do that, create that combined or merged or integrated division with the idea that we wanted really an integrated system. We had this, what we called a no wrong door policy, so that people should be able to go anywhere to get a comprehensive assessment and get the kind of treatment that they really needed to stay in their community close to their families. I think there's another big initiative that I want to mention, and that's the Bring the Kids Home initiative. We worked extensively with the Mental Health Trust, with providers, with the consumer community and families, because we discovered in the early 2000s that there were over 500 Alaska kids in out-of-state residential psychiatric treatment centers. And not only was it frankly unacceptable, but when I went around talking to people, it was virtually impossible to do what I would call family therapy if the mom or dad was in Nome and the child was in Utah. So what we did is we worked actively to develop in-state options so that Alaska kids didn't have to go out, and to bring those kids back home, thus the name Bring the Kids Home. And we worked extensively to create in-state options, and over time we managed to reduce that number to about 100 out-of-state kids. I frankly don't know what it is now, but around 2010 or so, we had as few as 100 kids in out-of-state placement. So I think that was another big initiative, another what I would call a milestone for Alaska, that with the integration of mental health and substance abuse services.
And I think it goes back to something Kevin said, is that, those are great. That was a great initiative. The problem is being able to sustain those community-based services so that kids don't have to go out. And I think that was one of our struggles. But I do have to say, Bill, I'm so pleased that you brought up the word prevention. Bill and I used to go around and round about this, because that's my real love, is that until we start preventing some of these issues, all of the social services from occurring, putting a stop to it so that we don't have to continue to build our service system and hopefully can maintain a better balance. So thank you for mentioning that. I do appreciate it. Okay, so thank you, everyone. Jeff, you talked briefly about the trust land development. Do you want to talk a little bit about the Mental Health Trust? Bill's mentioned it in the Bring the Kids Home. The Mental Health Trust Authority has had a lot of involvement in almost all of these issues. So could you just give us a little perspective about how the trust got started and where it's going and how it's impacting and working with all of our partners out in the communities?
Sure. Well, as I said, the Enabling Act at statehood created a 1 million acre land trust. And the state selected great lands, Homer Spit, Kenai River frontage, the Beluga coal fields, big areas of timber around southeast. And the idea was that the state would develop these lands and generate income to fund mental health services. But the state also got 100 million acres of general state land at statehood, and they rolled it all together. And over the next 20 years or so, about 500,000 of that million was taken out of the trust, often without any payment. We gave the big trees around Haines to the bald eagles. We gave Usabelli the ability to dig trust coal without much compensation. 5,000 individual Alaskans got pieces of trust land through our homesteading, agricultural projects, et cetera. So eventually this all came out when local governments selected a lot of mental health trust land. And there was a major lawsuit, and basically the Supreme Court said, yes, the state has stolen this 500,000 acres. And this sort of a lawsuit is really a lawyer's dream because the state was clearly at fault. And the remedy the Supreme Court had laid out was to put the trust back together. Unfortunately, there was no way to put Humpty Dumpty back together.
So some of it was just gone.
It was just gone. And you had eagles on it, you had people mining it, you had people building their homes on it. So after many years of litigation, eventually the lawsuit was settled in 1995. And what we realized was that the fundamental problem was that the trustee of this trust was the legislature. And it's very difficult for the legislature to focus on an undivided duty of loyalty towards a set group of beneficiaries over a set group of assets. So the biggest thing that came out of the settlement, in my opinion, besides the reconstitution of the 1 million acres and a cash endowment of $200 million, was the creation of the Mental Health Trust Authority, with a 7-member board of trustees who could make sure these assets were properly managed and could spend the income for improving the mental health program of the state of Alaska without a legislative appropriation, which has really been the strength of the trust, is that ability to use these assets to improve services without having to go through the legislature.
Yeah. Yeah, and you know, whenever I go to national meetings and I'll talk about the mental health trust, and people in other states just can't believe that we have something like this. So again, I think this is a decision that was made at statehood that has really benefited our state and our ability to have some of the services that many states struggle to have. So, thank you. Did anyone else want any comments about the trust?
Well, I would ask Jeff if you could describe who the beneficiaries are so people would have a better sense for the kinds of services and programs that we're trying to provide for this population of folks.
Sure. The beneficiaries are really all those people that were sent to Morningside. So they include not only people with mental illness, but people with chronic substance abuse problems, folks with developmental disabilities, people with dementia. Back then, you know, there were even some people that had severe cerebral palsy that just couldn't communicate, that got caught up in this whole thing. So it's a very broad group of beneficiaries that the trust is responsible for serving. And really serves as venture capital. This idea of having a venture capital fund to promote enhancement of a public mental health system is truly unique in the United States.
Yeah, exactly. Okay. Vernay, I wonder if you could talk a little more about the tribal behavioral health system. You talked about the fact that you certainly had you were here for many years. You have natural and tribal ways of doing things that have been centuries long. But you also have built, the state has built a very strong tribal behavioral health system.
Absolutely. just as the Mental Health Trust Authority is unique to Alaska, Alaska is also unique in that we have 229 federally recognized tribes that is spread all across the state in both urban and rural areas. And those tribes have a federal trust responsibility with the United States government, and then part of that federal trust responsibility is to provide health care and other services to the tribes. So early on, those services were provided through the Indian Health Service. As tribes got together and they united in various forums, they have come together to build what is the Alaska Tribal Health System overall. So for 229, so today it's 229 federally recognized tribes providing services through tribal health organizations and tribes administering their programs. They initially were receiving care, again, through the Indian Health Service. In many cases, they would leave their communities and never return. And looking at some of those early days, people would be put on a plane and they would never come home. This in itself is just a part of the tragic history that our people have faced and some of the trauma that they have experienced, that with boarding schools and a number of other issues, loss of land. So very similar, a lot of parallels in that history. They have come together and they have done something that is not matched anywhere else in the United States with regards to tribes. They've negotiated a single compact with the federal government, and they have taken over completely the administration of their health care services, including the behavioral health services that are provided. So it's completely self-governance in the state of Alaska, and creating programs that are run by the people and done in a way that is culturally appropriate, reaches back into the communities. Again, the community health aides going through the behavioral health aides program really brings in those community members that are intrinsically aware of the cultural aspects and providing care, and they bring that knowledge with them and marry it with the modern day medicines and approaches and put them together. So they are trained and certified with a very specific scope of care that are provided to the communities, but within the communities. So as you can imagine, some of our smaller communities can't afford to have a psychiatrist. They can't, there's no master level social workers in those communities. And so we have looked at innovative ways to bring that expertise into the communities using the community members there with technology. So so that we can bring those services closer to home and have those interventions at earlier stages.
Mm-hmm. And we know that having services closer to home is better. I mean, that's exactly why we didn't want people being shipped to Morningside or through the children going outside for treatment services. They do better when they're close to home.
Absolutely, and it's also rebuilt trust in the whole system of care overall, whereas early on, I went back home and I was visiting my grandmother. She had to go in for just a diabetes check, and she almost missed the flight because she was certain that we were taking her there to put her in a home. Mm-hmm. So she did not want to go and get on the plane. We had to reassure because that was the fear that if you got on that plane, you weren't coming home. And by after self-governance and taking over the programs, there is a faith and trust in that sense of ownership and being able to go back into the urban areas where you have other expertise and not being stuck there or going there to die. I mean, those are literally the thoughts of tribal members in the communities. And so it's really created a much more open and rebuilt that trust in the communities themselves.
Right. You know, I think another thing that kind of your conversation sparked is this issue of how broad our state is. I mean, small population, huge landmass, and the size of some of our communities are so small that it really is a challenge to get services in those communities, to get people coming to those communities and having the training to be able to provide the services. And I would say, and I think all of you could probably add to this, is that even in our rural or our urban communities, it is difficult to get some of those specialty positions that have that we need is psychiatrists, psychologists, master's level clinical social workers, you know, whatever it is. And I think that's another reason why we have the university system that can certainly do good training and help us keep people in the state of Alaska, keep them well trained and wanting to live here, and then through many of the programs that are happening through the tribal health system of training the aides and the different people in those communities to stay in those communities and provide services.
So Diana, maybe I can mention
Yes.
The work that we did when we began to integrate services around workforce development, because we did work extensively with the University of Alaska and with WICHE, the Western Interstate Commission on Higher Education. And as a result, we created the first psychology PhD program with an emphasis on community behavioral health. We expanded the social work program. We expanded the human services program. So I think we did some very innovative things at the beginning. I think one of the challenges now is still workforce. Providers struggle every day with having an adequate workforce, and if you do not have an adequate workforce, you don't have quality care, and you can't create access for clients and patients.
Exactly. And you know, I think our system has done a good job of also providing a lot of distance education, which again, for many of our smaller communities and outlying areas that aren't, you know, people who aren't in Anchorage or in Juneau or Fairbanks, that they can still get that training and become part of our workforce through an online program. And there's some very good programs, so it's very good.
Yeah, and I'd also like to mention, I think the advent of telehealth and telebehavioral health is really an important feature in this state because of the distances, and it allows providers in rural communities to have the kind of supervision that's actually required of them sometimes and is certainly necessary to provide those services, because you just simply can't get all of the people out in the communities. There aren't enough of them. We've had itinerant workers for years, whether they're psychiatrists, psychologists, medical providers, but I think that it's still relatively new and growing, and you know, there is an expense involved, but I think that it will help us expand care and allow people who are from rural communities to stay there and do the good work that they do.
And even though there's an expense, it's not the same expense of trying to get people, bring people in, train them, and then have them stay for a year or two, and off they go. So, yeah. Any other comments about that? Okay, so the next question is, I'm going to kind of start with Kevin and Pam, because you've been in the provider treatment arena. You're currently in it, and Pam, you've been recently. So we focused a little bit on the larger system. How do the people who are receiving services, receiving treatment services, and their families, how do they help shape the system of behavioral health care in Alaska? Not just the professionals, but how do the people receiving those services contribute to shaping the services we receive?
Well, for us, it's certainly in a variety of ways. We have individuals who are consumers of our service who sit on our board. Our board is made up predominantly of individuals who use our services. So in that sense, they have a direct input into policy and into programs and into what services are going to be delivered and how. We do routine kind of surveys of folks. We listen to their stories. We try and figure out what's the best way in which to deliver the care. And oftentimes the way the system is designed is not the preferred way that people would like to consume it. You know, if we think about an awful lot of folks, their first contact around a mental health or behavioral health or a substance abuse issue is not to a specialty mental health provider. It is to a primary care provider. And we are doing, I think, a much better job in recent years of being cognizant of that and trying to figure out how can we integrate with that. But it's still, I think, there's a lot of work that we can do to better tailor our services to be able to be delivered in ways in which our folks would like to consume them. You know, I have an awful lot of young people who come into my program who we're very concerned about their confidentiality and their privacy. They walk out of the appointment and they're texting furiously with their friends about what the doctor said. And they would like to be able to text with the provider on a kind of an as-needed basis when they need a question answered that is salient to them at that particular moment. And we don't have a service delivery mechanism. We don't have a regulatory environment that allows us to really provide that point of care service in ways that our consumers, our clients, our patients would really like them to be delivered.
And that is the new world, isn't it?
Yeah, I mean, you know, we often have the conversations with individuals about when they come in to see some of our specialists around, well, do you want to go have this conversation with WebMD, or do you want to have the conversation with me? Because, you know, you're here looking for my interest, and I'm not going to argue with the internet. But it is the new reality, and it's something that we need to take into account, that many of our consumers are getting their healthcare information in new and novel ways. Not all of that healthcare information is necessarily really good, but there are also some really good places for them to get it. And we've seen health literacy and mental health literacy increase as people are able to access information online, and they come in with really good questions. They come in with really good challenges to us about what are you doing, why are you doing it, how is that compared with what I'm reading? And I think it really helps to spark a wonderful conversation about how we can adapt and modify how we deliver care and services in a way that makes sense to the folks who want and need us.
You know, and something that just popped in my mind as you were talking about them texting, and you know, I think that goes back to the fact that we have reduced the stigma about these things. That younger population is not nearly as, you know, hiding some of these conditions. They're willing to talk about it and out there. So that does kind of change the dynamic of how we interface with those folks. Pam, do you have some comments?
Well, I think my observations are similar to what Kevin said, but I'll just add that historically we've had some feedback loop built in there where if every few months there's a treatment plan review with a client, then they may tell us how they think their plan is going and whether it's helping them reach their goals that we've identified together. And then we have like an annual anonymous client written survey and those types of things. But I remember too in one of our national accreditation surveys that the surveyor said, well, you know, sometimes the best way to get information is just like at a social event or something and just chatting with people who are using your services. And I think that's true. And I know that in conversations I've had with people who work in the South Central Foundation NUCA system of care, that's a whole different way of providing services that I think currently, based on the parameters we have in our state system, it's not possible to do all those things. But there are children emailing their dentist at the drop of a hat or their other provider, and the focus of trying to work with the whole family, I think, in providing primary care and other services is really a good way to go. And often when I'm thinking about the system changing in behavioral health, I think about, well, how does the primary care world do this? And I know I can get into the account that I have with my primary care provider. I can ask questions. I can look at my record. I can make a request. And so I think you're really on target there, Kevin. And I think that we need to develop that. And I just want to insert here, one of the things I've really appreciated about the Alaska Mental Health Trust Authority is the opportunity for the providers and the beneficiaries, providers of other organizations to try some of these innovative things, to get enough capital to do a pilot project, or in our case, when I was the director at JAMI, to help us get the grant out the door and support us in developing the integration of primary care with our behavioral health program, which has just been amazing. And you know, a multitude of other things that the trust has really helped us with, that have resulted in better care and more options for the people that we serve.
Mm-hmm.
So Diane, can I talk about the importance of listening to family members and consumers? I know when I had these quote-unquote higher level positions in state government, I always made a point of listening to consumers. I still remember nothing about us without us. Mm-hmm. Nothing about us without us. That is a significant statement about consumers and how they want to be part of the solution. And I spent more than a few hours at Ionia down on the Kenai. I spent more than a few hours listening to the folks at NAMI. I think what the Mental Health Board and the Advisory Board on Alcohol and Drug Abuse do are absolutely essential to creating a system that best serves the people that we're supposed to be serving. So I don't think it's an add-on. I don't think it's a supplement. I think it is a critical piece of what we do, and we need to work really hard to make sure we don't lose sight of that.
Mm-hmm. Yeah, I would agree with that.
Well,
Jeff?
another aspect of that too is not just the individual advocacy, but actually making peer support and peer services an official part of our system of care. Recognizing that life experience and that ability to identify with each other can be as or even more important in some cases than the therapeutic treatment offered by professionals. That's why the creation of the peer support specialist as a legitimate part of a treatment team and really trying to integrate that into our system of care is a really important step forward in making sure that consumers have access to a whole range of assistance.
Mm-hmm. And for me,
I just would like to add that I think that a lot of things are coming together to create a more holistic approach to the care of individuals, from the integrated approach with the primary and behavioral health, removing the stigmatization of it all, telehealth, allowing for new things, and even workforce development. And it's all moving together still. I mean, even with the community health aides, behavioral health aides, we're working with partners, and the partnership is critical to that advancement as well. So we're working with partners to develop the behavioral health aid programs further, the dental health aid programs and the community health aid, so that we can take it to the next step, and that we can develop those individuals in those remote communities and build a career for those individuals that are beacons to the other individuals in the community as well, so that they can aspire to these different roles. What we're learning about ACEs and the impacts on the brain with regards to addiction is enlightening us all. And again, with the health literacy, starting to build that, and again, all of it coming together to break down the stigma that has been a huge barrier to the advancement of our health and well-being.
Mm-hmm. You know, listening to all of you, it truly is amazing the progress we've made. Because I think about that. It used to be the professional knew all the answers. supposedly. It was the doctor, the psychologist, the psychiatrist, the social worker. They knew what to do. They told you what to do. And we're really very far from that now. And including consumers, including beneficiaries, including clients in these conversations, and making them a partner is critical to having quality care for people. So, thank you. Okay, the next question is, as our behavioral health system of care has been evolving, is there a challenge that comes to mind that we have kept struggling with over the years and that we've not been able to quite tackle? So who would like to start on that question? It's kind of a big one.
Well, let me start. The one thing that comes to mind is, frankly, a frustration in not being able to better serve people who do not have severe problems. So what we used to call general mental health, the whole notion of intervening early, working with individuals and families before the problem becomes so severe. The Medicaid, using Medicaid as the primary funding source for the behavioral health system has made it very difficult to serve those individuals. And as a result, they many times go without service and end up with more severe problems in higher levels of care. I think that is, at some level, almost intractable, but I think we can figure it out, but it's been very frustrating from my perspective.
Yeah, and that's been going on for some time.
Yes.
I remember when that switch happened, and it is very difficult. Again, being a preventionist that I am, if we don't get care early, it just manifests into a much more serious situation. So we end up, by trying to, I guess, save money, we actually increase the cost down the road.
If I could add to that, I think that by not addressing problems at a lower level, at an earlier level, and particularly for persons who were incarcerated, at one point we had actually more services, I think, than we do now for people who are incarcerated. Mental health services, chemical dependency services, transition services, step down to a certain extent from incarceration or from residential or inpatient treatment. We needed more of those, not fewer. And we are still, like other states in the country, using a correctional system as the largest provider of mental health services and addiction services. And guess what the biggest recidivism issue is? It's using alcohol or drugs. And now with the added opiate crisis, we're really struggling. And my fear is, let me reverse that. My hope is that we put more resources into developing and supporting treatment programs and other prevention services so that we don't build more prisons and lock up people who need help and then release them without having the appropriate services. Some of them have never lived successfully independently as adults in their lives, and they need a lot of help. And we have models in other countries that work far better than ours. And so I hope that our policymakers consider putting resources in places that can produce more effective results rather than just building more prisons, I guess, to be blunt about it.
I have to absolutely agree. I think what we have is just huge gaps in care and huge gaps in programs and being able to intervene at those earlier stages where you have better outcomes and healthier outcomes. Right now, the systems are, when you're rationing care, you're really forcing your individuals to that higher level. And you're costing your society a great deal more in trying to address those issues later. And so if we could look at ways to create those more intermediate and earlier interventions, it just produces better outcomes all around.
Exactly.
I would say that integration is a major challenge. We have made phenomenal strides, but I think there are still lots and lots of interesting barriers, both in terms of the vertical integration. We can integrate at the point of care, but oftentimes we're dealing with separate billing systems, separate billing rules, separate credentialing kinds of requirements, and you move further and further up the policy and particularly the payment system, and we don't have a coherent, integrated model. We have more of a co-located or a cooperative model, but we really don't have a really integrated model. And I think the second area of integration that we really need to meet the challenge of is that of horizontal integration. If we think of most of what drives the cost of healthcare, it's not the things that happen typically within the four walls of our programs. It is the social determinants of health. It is it's the poverty, it's the food security, it is a variety of other challenges that we have pieces and parts that address it, but they're really not integrated in a coherent way that allows us to efficiently and effectively marshal them together to meet the needs of our families and our communities. And so I really think one of the major challenges and one of the really cool opportunities, and I think it would help to address Bill's comment, is that integration notion, and it's also integrating across the spectrum from the prevention to early intervention to treatment and to recovery. It is really looking at that, if you will, 3 different dimensions of integration.
And are we going to get there?
I think we can. I think we have the opportunity with the 1115 kind of policy developments being done and a bunch of the other policy developments that are being talked about. They are essentially going to create the fence under which we get to play in the pasture. And depending on how those fences are built and where they're built, we're either going to make it possible for us to do that, or we're going to make it more difficult for us to do that. But we do have the opportunity of creating a way in which the next 10, 20, 30 years of behavioral health in Alaska can really meet the promise of integration and meet the promise of comprehensive care.
And yes, go ahead.
And we have not gotten rid of stigma.
No, we have not.
When I was at the Mental Health Trust.
It's better.
It's better.
But it's not gone.
But, and I disclosed my alcoholism at a public health conference.
I remember.
I
was
had
there.
not made it back to my office before public health professionals were calling my trustees saying, "Did you know you have an alcoholic as a CEO? What are you going to do about it?" And just today, I was watching a video of a restaurateur who offers free meals to people who have mental health and substance abuse issues. And even he talked about how people think he's crazy to treat these people like real customers, even though they can't pay. So we have a long way to go before we really treat these illnesses like we do measles or the flu.
Mm-hmm. You're absolutely right. It's still a struggle. And, I was thinking about, as all of you were talking, it goes back to just some of the basic needs that people have too. And I don't know if all of you have seen the data that was put together for the Juneau Housing First program, where just by giving people with mental illness or with substance abuse a safe place to live, it reduced their drinking, it reduced their calls to the police department, it reduced their ER visits, it reduced, basic needs for people. And because of some of the stigma, we tend not to do that. And we think, well, they don't deserve it. Why should we give them housing? But you go back to some of the conversations you've all been having about all of this. If we don't have healthy people that can be contributing members of society, then we have unhealthy individuals, unhealthy families, unhealthy communities, an unhealthy state. So how do we start really looking at that holistic picture? Because that's certainly the way I've always thought we should be looking at it, but it's hard to get there. So, any other comments on that one? Good conversation. All right, so This is a touchy one probably right now, but obviously funding and available funding is a major factor in access to treatment. We've touched on it a little bit. If you don't have the right services or enough money or enough resources, you're not going to have appropriate treatment. So both how quickly people can get treatment they need and the services that are available are part of the funding solution or the funding problem. Can you share some of your perspectives about how this has impacted our system of care, and what kind of a funding mechanism do you think would be more appropriate to make sure we have that for people all across the state of Alaska? Who would like to tackle that one first? Bill, you look ready to talk.
Everybody just seemed to be looking down this way.
The man who ran the department.
Well, yes. So for people who don't know, essentially what we have is what's called a fee-for-service system. So when people come in the door, the provider provides some sort of service and they bill for the service. And the more, essentially, more or less, the more service they provide, the more revenue they generate. That is a recipe for it not being sustainable, and it's not sustainable. The current way we fund not just behavioral health services, but health services in general is not sustainable. And thus all this discussion here in Juneau and throughout the state about what do we do with the Medicaid budget, because it just keeps growing. So I think we've got to be creative in looking at other ways that we pay for service. So on the health side, there's a lot of discussion about pay for performance and pay for value. So rather than just paying for when people come in the door to receive some sort of service, we've got to look at funding that's different. The tribal system has what's called an encounter rate. So rather than, 10 individual services provided to somebody, how can you look at a comprehensive array of services that person might receive, and that the provider gets reimbursed at a single rate for that? Mm-hmm. So there are examples of what we can do to fund the system differently, but it means a fundamental change in how providers are reimbursed, which can be very anxiety provoking. There's a lot of angst amongst providers about the possibility that they're going to have to do things differently in order to get paid for the service that they provide. But there are options, right. And I think we need to be creative about implementing some of those options.
Well, and Kevin, you brought up the 1115 waiver, which is a Medicaid waiver for behavioral health services that begins looking at different ways of payment.
Yeah, because fundamentally, if you think about the Medicaid system, Medicaid was originally created to pay for medicine activities. So if you broke an arm, right, you would have somebody set the arm and take care of you, and ultimately the arm would get better. And we have used, in Alaska, we've used Medicaid very creatively and I think very effectively to provide all kinds of non-medical kinds of things, social services and other things. And fundamentally, I think as we have learned, and as the country has learned, that a lot of the things that contribute to medicine and to people's health has nothing to do with medicine. And so the question really is, how do we create a funding mechanism that pays for those things that make sense, that actually ultimately contribute to good outcomes, to better health? I remember way back in the day when we had lots of grant money. We had an individual who was cycling through the hospital and we couldn't quite figure out why. And then suddenly somebody finally asked the question, because they went out to the person's home and realized that they went to the hospital because they were cold. We bought them 3 or 4 cords of wood, and we didn't see them back in the hospital for like 9 months. And when they ended up in the hospital, they really needed to be there. And so what are we paying for, and where are we paying for it? At what point does it make sense? We have a lot of our behavioral health consumers that are going to emergency rooms. Well, what's attractive about an emergency room? It's open 24/7. You get seen relatively quickly. There are nice, warm, and friendly, caring people there. So if we don't want our folks to be going to the emergency room, how can we create that same value for them, the return on their willingness to sit there for 2 hours in a waiting room in order to get something? How can we create them getting that at some other point in the system, and how do we pay for it in a way that makes sense both for the policymakers and the patient and the provider?
Well, some hospitals do have a social worker who is assigned to the emergency room, who is tasked with trying to identify what those issues are and help that person get some of those needs met. And that's occurring around the country in some places. I think that the challenge is, as you said, how to pay for this. I mean, in our community, it's somebody part-time. And, you know, I think the coordination with the providers, if the individual happens to be engaged in treatment somewhere, is important. But it seems like we keep circling around this whole idea that we can provide top-notch services to people, but if we're not looking at the whole person and their life circumstances and trying to help strengthen their support network and ameliorate their circumstances, we're not getting the kind of outcomes that we hope to achieve.
Exactly. And for Dave?
I agree. I think a sort of multi-level approach or different ways of approaching different things is necessary. For the tribal health system, we do have the encounter rate. It is cost-based, and so the numbers are there and justified and reviewed and approved through a very structured system in order to do that. I definitely see the value of value-based, but in small communities, you don't have necessarily the economies of scale to be able to support that. And so taking a multi-pronged approach may be necessary. When we had Medicaid expansion, it opened the door to many different opportunities and allowed us to design programs that could respond to the demand. Grant programs are finite, and you have to sort of divvy that out, and what Medicaid expansion allowed you to do is really respond to the demand. But not all of our programs have the same access to Medicaid and the ability to bill Medicaid. So those, and it also is limiting again as to what you can do with Medicaid dollars. So the grant programs offer a level of flexibility that the Medicaid program does not. So taking a sort of multi-pronged approach is important, but the investment is what is needed, and the value in those, and seeing the returns and being able to identify those returns, I think, is really important. I think that we've done a great deal to show the improvements in health for our people, and continuing to be able to do that, I think, is one of the keys to addressing some of the issues regarding funding overall.
And it's really the investment and the commitment, a commitment to wanting to do these, to provide good services and to see good outcomes. Jeff, any comments?
Well, I think it's also what you pay for. And I know you're sympathetic to prevention, and we haven't fully integrated a prevention model into our system of care. For example, we talk now a lot more about adverse childhood experiences and childhood trauma and the impacts that has, but somehow we still miss the fact that children grow up. And when people become adults, we stop talking about ACEs.
Even though they're still there.
But that trauma is still there. Exactly. It still is what's driving a lot of their difficulty. So again, I think it's looking at a more holistic payment system that puts resources into areas like prevention and dealing with these early intervention issues, which is really going to pay off in the long run.
And, we were talking about this at my office just the other day, is that we know where the high-risk kids are because we see them. They're the kids of those coming into the mental health centers. They are the children of those who have substance abuse problems, the children of those who are in our jails. And they have some of those traumas. We know who and where they are, but we haven't done a very good job of really targeting our approach to to meet the needs of some of those high-risk kids that we know are going to most likely have problems down the road. So I think it's resources, it's commitment, it's effectiveness, it's all of that. And something you said, Bill, I think is really important in this is it's hard to change. Especially as a provider, when you're counting on and have to have that money to sustain your program, and that idea of changing how you're going to get your funding it's scary. It's hard. I mean, people all are talking about it all the time. Well, if we change, what will happen, and how will we get our money, and will we be sustainable? So it's really going to take all of us working together to really figure out the solutions to some of these funding issues.
I think for many folks in the provider community, there's an interest and there's a willingness and a desire to change, to do, things better. The question is how to survive the transition, because many of our providers are already operating on pretty razor-thin margins, and any disruption to that process is one that could potentially threaten the viability of the organization. So part of the issue is from a policy development and from a change management standpoint, how does the state invest in an appropriate way in the change to permit organizations and providers and whoever else figure out how to do it well under the new system, and to have enough time and opportunity to learn those lessons without being catastrophic for many of the providers.
And having a little cushion while that change is happening.
Yeah.
Yeah. Well, it's not one we're going to solve tonight, but I think it is definitely one that weighs heavy on everyone providing services, those who are needing services, our policymakers, our funders, our decision makers are all considering these issues and trying to figure out the best way to go forward. So the next question kind of flows from the conversation we just had, and unfortunately tonight we were not able to have a provider who specifically focuses on children's services. But would anyone like to share their perspective on how the behavioral health system in Alaska has affected our children's health, or do you feel like we have a good system for children? And I think some of the same could be for our seniors. We tend to see the middle range of ages, but seniors clearly have substance abuse and mental health issues, children do. And how are our systems dealing with those on the outside edges? Anyone?
Well, better than it used to.
Yes, that's good.
Bill mentioned the Bring the Kids Home initiative, where the problem that we had is that if you blew out of your home, there was really no service for you, no off-ramp until you got to Utah. And starting to build, therapeutic foster homes, in-home supports for natural families, group homes, really try to build that system up. We've had a tremendous reduction. Now I think it's starting to backslide. This is the second time we brought the kids home. We did this back in the 80s. So you have to be internally vigilant about maintaining those systems of care for families. And we've talked about ACEs and recognizing that a lot of the difficulty children face are coming from childhood trauma, much of which is coming from their family. And so it's not just a children's mental health system, it needs to be a family mental health system.
And Kevin mentioned that earlier.
As I've said, before, these children didn't spring from the head of Zeus. They've had a lot of trauma in their lives generally, and we need to focus on that as we go forward.
And I think we've made great strides in terms of helping kids and building out the system for kids, but I think the point is well made that probably the next major iteration is how do we build that for families? because we've created somewhat of a system that has invited families to drop their kids off for the professionals to fix and put them back in the family. And that doesn't work terribly well. And it really needs to be a family-based approach, as you mentioned, Diane, that we know where these families are, we know where the kids are, but we don't yet have a system, and again, hopefully through the 1115 and the models of care, we can have a system that permits and encourages that the family be the focus of care and treatment as opposed to the kid itself as the identified patient.
Yeah. Brene.
I would like to offer that we're on the cusp of something new, in that the state of Alaska has entered into a compact on children's services. And I think that there's a real opportunity, if you look at the model with the Alaska Tribal Health System and the self-governance and operating the compact for health services overall, it has done so much to help improve the services and health status of our people, and increasing our longevity and just the services that we provide. And I am optimistic and excited to see where it goes. I'm hoping that the state continues to embrace this approach as we move into the future, and supports that compact with the tribes to provide those services for our people. I think it shows some real promise.
I agree with that. Definitely shows
Could I
promise.
add one comment?
Yes, please.
You mentioned earlier that something that made me think about this, that children grow up and then all of a sudden we forget about those adverse childhood experiences. And one area that I think we struggle with, and probably every other state does, is a lot of times children with really serious emotional disturbance and mental health issues may get quite a few wraparound services and supports, and then all of a sudden they age out of that system, and their parents and them are just cut loose. They don't know what to do. They're not really connected up with the adult mental health system, and it is not set up or funded to support or provide the kinds of supports that they enjoyed when they were younger. And if that isn't a recipe for failure, I don't know what is, because they leave that system where maybe they were functioning as well as they could at the time, and they're just lost. And even if they're still with their families, their parents are saying, we can't do this alone, we need your help. And I really think that when we look at system design, somehow we need to figure out a way to bridge that gap and make a smoother transition, so people don't just unfortunately end up with legal involvement and incarcerated, and then looked at in a totally different light, a far more judgmental light by the courts and the correctional system. And it's really unfortunate, and we can do better.
I'm really glad you brought that up, because that is a huge piece of our system failure. And it goes back to what Kevin was talking about as an integrated system.
Right.
It should be integrated not just on the services, but on the age as well.
Right.
Because when I was working in child protection, it happened all the time.
Sure.
Kids were getting services, turned 18, and boom, they're out on the street and they're homeless, and
Right.
all the other things that happen. And especially if they already don't have a healthy and supportive family, there's no place to go. So that's a really key issue, I think, for many of our programs.
Diane, let me talk a little bit about seniors.
Yes,
Because I
please.
think it's a population that really, talk about stigma, I think there's still a lot of stigma around mental health and alcohol and drug use or abuse amongst seniors. It's extremely difficult to get somebody who's older to go to a community mental health center. There's no way I'm going to that place. I'm not crazy. I don't care what you say. And so we need to be a lot more creative about how we get services to that population. When I was in Wasilla at the Community Mental Health Center where Kevin is now, I had this idea that maybe we could put a community mental health clinician or social worker at the senior center. And we tried this in Palmer. had the person actually at the center. They didn't even identify themselves as a clinician. They were just there. If people wanted to come and talk and listen, they could do that. The problem was we couldn't figure out a way to fund it. We had a special grant, but once the grant went away, there was no way to pay for it because they weren't technically providing the kinds of services that you could get reimbursed for.
A billable service.
A billable service, right. So I use that as an example because I think we've got to figure out a better way to get services to seniors, elders, in a way that's much more acceptable and less stigmatizing. The other big problem we have that people probably don't talk a whole lot about are the folks in pioneer homes. And when I was in the department, there's a lot of folks in pioneer homes that have significant mental health problems and behavior problems. And in many instances, the staff in those facilities are not really equipped to work in a good way, in a positive way with those individuals. And so I just think we, as a system, need to do a much better job of working with older folks.
Renee?
I just wanted to tack on. I think that he's absolutely right in that when you think about the stigma that still exists and we're still grappling with, I would say elders are much more susceptible to that than the younger generation. So there's a generational difference between. I mean, it's not like they're protected, but they certainly have a greater level of sharing and therefore some level of understanding and acceptance that the older generations, I think, are not benefiting from or have dealt with for many decades of early on experiences that become part of your fabric and your being.
Mm-hmm. Yes,
And you think about the way that we think about this on a state policy basis, that the Division of Behavioral Health is, we talk about kids and we talk about adults to 64.
Right.
And then it goes over to senior services. And it goes to waiver and other things. But, how much integration is there between the senior services arena and the Division of Behavioral Health? And, there are well-meaning people who have lots of conversations, but I don't know that we have a really coherent. It's like the person with attention deficit and hyperactive disorder. They turn 18 and magically they're diagnostically cured because as an adult they can't be diagnosed that way.
Right.
And so when you turn from 64 to 65, you magically don't have any more mental health problems because the system doesn't define you as a recipient of service. Mm-hmm. That's really kind of crazy.
It is kind of crazy. And kind of going back to what Bill was saying is that, I think another thing we know about seniors is that sometimes it's just loneliness. Sometimes it's, they've lost their partner, they've lost their friends, they might start using alcohol a little more than they used to. And if you could have more of these informal kind of services to assist them, that there can be positive outcomes. So clearly, you're absolutely right, Kevin. We don't do a good job of transitioning kids from kid services into adult services, nor do we do a good job of transitioning from adult services into senior services. So something we all need to be paying attention to. So we are winding down, and so we've actually done a pretty good job. Almost got through all of our questions. But what I think I'd like to do is to end on kind of a high note. Let's end on a positive note of where we see our systems going. And, kind of if each of you could just talk just for a minute about kind of what are some of the successes that you see in our system, both from the personal, personal clients that you've worked with or systems successes, and how do you see how optimistic are you all for the future of our behavioral health system? And I think we have about a minute for everybody. Okay. Jeff, you're going to start.
There we go.
I'll start. Well, it's hard to know where to start because there are a lot of positive things to work on. We've talked about a lot of them here tonight, whether it's bring the kids home, integrated care, housing first, meeting people's basic needs, not conditioning basic things, sobriety or other things, integrating the consumer voice,
Yes.
not only into individual treatment, but also as part of the system and legitimizing that as a part of a comprehensive system. So I think there's a lot of positive things to build on as we go forward.
Good. Renee.
I agree, and we have talked about some of those and the partnerships that we have. You know, like the community health aid was basically, it started with no official training. We created the certification boards and such, and now we are working with the university systems and creating accredited programs that we can get folks to get scholarships for, to help with those with you know, paying those costs as well. So I think there's developments that are happening that are very exciting, and I'm very happy to see, you know, the breaking down of the stigma. We have more celebrities talking about mental health issues that are helping to just crash down those barriers. And again, that's why, you know, I think the youth are starting to really benefit from that, and the conversations are happening. So I'm very excited about that. Gosh, there's so many things that's. There was one more, and if it comes back to me, maybe I'll ask for that 1 second, but I'll go ahead and pass it.
I'm optimistic too, and having just retired a couple of years ago, I can think back of many, many accomplishments that have come about in both of our fields. And I think my only caveat is, as they say, something like, if you don't know your history, you're doomed to repeat it. And when you've been around the system long enough, you see people coming up, or younger people coming into the field saying, oh, we've done this and it's never been done before. And you know it's been done. And I think that there are a lot of good programs, including transitioning, you know, from youth to adult services, or helping older citizens with their mental health issues and so forth. But every time we have like a new administration or major personnel changes, that history gets lost. And my only concern is that, you know, we lose the ground we've gained sometimes, or we have to keep taking the same hill again, to put it in military terms. But overall, I think it's been more forward momentum, and I am really optimistic about the future.
Right.
I think I've got a lot of hope, because when I look at the landscape and I see the level of community engagement, the number of coalitions, the number of cross professionals and grassroots and different segments of the community that are talking to each other that haven't talked to each other before, around issues of mental health, around issues of substance abuse, around issues of transportation, and just general community health. I think the activation of the community and the development of coalitions and the conversations that we're having, I think really provide a very fertile ground in which solutions can be created, and that those solutions can be very community specific.
Right.
Well, I'm optimistic because in Alaska you can make a difference. Yes. We are a big state, but we're a small state. And everybody in this audience, everybody that's going to be watching this program, can make a difference in what the mental health and substance abuse system looks like in Alaska. You have access to your legislature. You have access to the administration. Where else can you walk down the street and run into your U.S. senator? You have a lot of influence. You really do have a lot of influence, and you can make a difference. And I think we have done some very good things. The panel has highlighted those things. And I think we build on that. There's, you know, the world, it's bumpy. It will be bumpy. Turbulence.
It will never be smooth.
It will never be smooth, but we can get through it. I'm sort of a realist, but I'm also an eternal optimist. And I think we can get through this, and I think we're going to come up with a solution that is going to be the envy, frankly, of not only the rest of the country, but the world.
Excellent.
How's that?
That is a great way to end this conversation, because truly that is what this is about, is that we all do have a role to play. We all can make a difference. That was one reason I stayed in Alaska. My mentor told me, you can make more difference in Alaska than anywhere else you live. And she was absolutely right. So I want to thank the panel. This has been a great conversation. And as I said earlier, this is just the start of a conversation. But as Pam just said, we don't want to forget our past and continue to make the same mistakes. But let's learn from our past. Let's continue to grow. Let's keep this going. And maybe we could have a round of applause for this great panel.